Good morning, everybody. I'd like to welcome you all to this first or maybe second session in this room this morning. It's about patient blood management with autologous platelets and hemostasis management. It's a great honor for me to chair this session. I will start with patient blood management, the latest guidelines, and then we have two very important, very interesting presentations. First by Pierre TB from the United States on the implementation of new VET system, viscoelastic system and the results thereof. And then it's Bertrand Rosec from Nantes, who is talking about the clinical use of this new cell salvage device that is able to retransfuse and salvage, or first salvage and then retransfuse, of course, platelets, which could be really a game changer in this business, particularly in cardiac surgery. So first of all, I start with the patient blood management, the latest guidelines. Of course, I have a wide spectrum of activities, less so conflicts, I would say, but anyway, it's up to you to judge about this. I have lots of interactions with companies and foundations. And of course, patient blood management, as you all know, is a wide and important concept. It's based on three pillars to correct preoperative anemia and iron deficiency. This is not the topic of today, or not particularly. To reduce perioperative RBC loss, this is the topic of today's session, and then optimize anemia management, and everything, including the reasons why this concept is so important, has been described in 2019 in the policy brief by the WHO. Now, there are interesting guidelines, all very new and very important on different aspects of patient blood management, like the 2022 ESC guidelines, the European Society of Cardiology guideline on cardiovascular assessment and management of patients undergoing non-cardiac surgery, but it could as well include patients with undergoing cardiac surgery. And I think it is very interesting that the cardiologists clearly state it is recommended to treat anemia in advance of non-cardiac surgery in order to reduce the need for RBC transfusion during non-cardiac surgery. And they do this for 20 years now, assign a class 1 level A level of evidence to treat preoperative anemia. This is the highest level of evidence you can assign to a recommendation. They also come up with a class 1 level A recommendation saying that if surgery is expected to be associated with a blood loss of more than 500 mL, use of washed cell salvage is recommended. So use of cell salvage is a 1A recommendation. And third, it's recommended to use point-of-care diagnostics for guidance of blood component therapy when available. So this is also very important. Personally, I would not have written when available, because if it's a 1A recommendation, it's the obligation of the hospital to have the device ready to do so. Now, cell salvage has been, of course, investigated many times. And a few years ago, we did a meta-analysis but only on prospective randomized trials. And you can see that you can drastically reduce the percentage of patients with allogeneic blood transfusions. The number goes down of the RBC transfused if necessary. But even more important aspects or benefits have been shown, namely the percentage of patients with post-operative infection, minus 28%, length of hospital stay, minus 2 days, and mortality was not changed. But see, these two are very, very important aspects, and also clinically and financially very significant. So this is Pierre Thiby's STS guidelines on patient blood management, and they again say the routine use of red cell salvage is a class 1 level A in cardiac surgery, and transfusion algorithms are also a class 1 level A recommendation. So this leaves us with the conclusion that, it's highly interesting that the patient blood management, the 3 pillars, the first pillar is a 1A recommendation. Then in the second pillar, cell salvage is the 1A. Coagulopathy, the avoidance of coagulopathy or the individualized goal-directed treatment thereof is a 1A recommendation, and tolerate low hemoglobin values is another 1A recommendation. So all we are talking about has been shown and has been judged by major professional societies as a 1A recommendation. And the 1A recommendation is a must in my view, in my personal view, on that this must be implemented. Now, the technology is there, of course, from ROTEM devices, different generations, TEC devices, different generation, ClotPro, and also the Quantra. These are relatively similar. I mean, you may find differences, but in the end, it's relatively similar technologies that help us finding out what is the individual coagulation problem a patient has now, and what to do to individually goal-directed treating this problem and not just pouring in some whatever blood products. So cell salvage, to summarize, is a 1A recommendations. The benefits are tremendous. RBC transfusion goes down, clinical outcome is improved, and of course it should be also used in cancer surgery. The limitations, it's not applicable in non-sterile surgical fields, and the RBC suspension in the traditional cell salvage does not contain any coagulation potential. But there is a new technology that has been prominently published in anesthesiology 2 years ago, a device that is able to retransfuse not only the RBCs, but also a significant fraction of the platelets. And these platelets have been looked at functionally, and they seem to work okay. So my conclusions are that patient blood management is the new WHO standard. All central patient blood management measures are 1A recommendations by international professional societies. So let's just implement them. And I'm very interested now to hear from Pierre Thiby what his experience are in his center when he introduced these methods. Thank you very much for your attention.